improvement and digital enablement team here at Eastern Melbourne Primary Health Network. We're going to start today's session with our acknowledgement of country. Next slide, please, Tara. Eastern Melbourne Primary Health Network acknowledges the Wurundjeri people and other peoples of the Kulin Nation on whose unceded lands our work in the community takes place. We pay our respect to Aboriginal and Torres Strait Islander cultures and the elders past and present. MPHN is committed to healing of country, working towards equity in health outcomes and the ongoing journey of reconciliation. We recognise and value the knowledge and wisdom of people with lived experience, their supporters and the practitioners who work with them. Celebrate their strength and resilience in facing the challenges associated with recovery. We acknowledge the important contribution they make to the development and delivery of health and community services in our catchment. Next slide, please, Tara. So some housekeeping today. All attendees will be muted. We'd like you to use the chat function up the top of the screen to add your questions. Grant and Kylie will be happy to answer these during the session, and there'll also be time at the conclusion of the session to ask further questions. We will be recording the session today, and all employees, attendees will be provided with the recording and a copy of the slide deck that Grant and Kylie are referring to as well. Next slide, please, Tara. This is the agenda for today. We'll be going through the new enhancements to the 4.3 edition of Medical Director, recording measures, recording immunisations, recording cervical screening, managing recalls and recording contact, recording social and family history, including recording alcohol and smoking, keeping past history items relevant, creating letters, data quality and data cleansing, user preferences, and the use of the My Health record, both accessing and uploading. So got quite a lot of content to cover today. So I'm going to hand over now to Grant and Kylie, who between them have a wealth of experience, 30 plus years of experience at Medical Director. So thank you, Grant. You're going to start.
Thanks, Barb. Thank you, folks. My name's Grant Smith, Medical Director, Telstra Health Practice Consultant. Thank you for joining us all today. I've got my lovely colleague Kylie driving with me today. Full acknowledgement to Kylie and her fantastic slide deck. Kylie will make the slide deck available to the good team at East Melbourne PHN. I think after today's session, I think she's already given a copy of it to them up front, but I know there's been some tweaks in literally the last couple of hours. So in regards to that very comprehensive slide deck here, we do have a bit of time today, so we will address the slides that we're going through. If you were at yesterday's GP session, we only had an hour, yes, only half the amount of time we had today, so we were pretty quick. Today we'll be able to spend a bit more in-depth time today. So first thing off the agenda today, we're looking at the new 4.3 enhancements. The 4.3 was released on Valentine's Day this year. If you didn't receive your bunch of flowers with your 4.3 upgrade, please make sure you contact hello@medicaldirector.com and they'll certainly look into what's gone wrong. That's a joke, by the way, folks. Don't send them an email, please. They'll get me in big trouble. But certainly, I might hand over to Kylie because Kylie's did a fantastic job on these slides. So Kyle's over to you, mate.
Fantastic. Thanks, Grant. So basically, first of all, what we do want to double check is that if you have upgraded to the 4.3, just at the top left-hand corner, you'll see Medical Director Clinical 4.3. If you are on 4.2, these options won't currently be available, but once the upgrade is done within the practice, you'll be able to see. So as you can see, we've got a wide range of new features that have been added to our latest version, which we're quite excited about. The main reason is obviously over the last couple of years we haven't had any improvements that have actually been for you guys. It's more for Medicare purposes and, you know, keeping up for accreditation purposes and stuff like that. So what we'll do is we'll jump in and have a look at some of these. As Grant said, I do have a individual 4.3 slide deck for everybody, as well as a nurse one. So this means that you'll get different slides based on different criteria as well. So each of those lists will have a different slide deck here. So basically the first one in the 4.3 is sending of emails. So we are able to do that now through the documents, results, letters, or correspondence tab. So just by going in underneath where you've got, like, you'll probably potentially be sending SMSs from there currently from one of those tabs. So what you'll need to do is just click on the send email. We can send this with a protected password. Okay, so usually it's just the date of birth. You can obviously alter that potentially and make up your own codes and stuff like that as well. It's definitely up to your practice and what ruling that you guys have there as well. We
also send multiple documents there as well, Kylie. If you do a multi-select on the screen, like you might have a medical certificate and a specialist referral that you want to send to a patient or to a client, you can do that at the same time. Just multi-select, either using the control button to select multiple entries, or shift to select a range, and then you just use that drop down there next to that little send email, as you see there on the screen now. Back to you, Kylie.
I'd probably recommend filtering. So obviously if there are certain things that you want to be able to send, if you do your filtering first, that will obviously allow those lists to be quite, easy to read as well before you're having, you could have lots and stuff in there. If you are finding, obviously, potentially this is just a tip, if you found that you went into letters and the letter that you're potentially looking for isn't there, definitely make sure you go into correspondence, because the correspondence has letters, documents and results. So it may have been added to the wrong section, so that'll allow you to go in and address that by just right clicking, going into the details and then adjusting back to the letters. Okay, and also just making sure that your filters based on whether or not you're looking at the date created and things like that are appropriate as well, because you may have selected subject and that'll obviously alter those out of date order.
I think we might show that in the software a bit later when we finish with this section here. I think we'll go through that when we're talking about some of those quality areas we talked about in the agenda. But I think we'll talk about that as well in terms of that filtering and how important that is as to what information is displayed.
Fantastic. So the other one is obviously of importing your emails in as a letter. So potentially currently you may be going through your scanning and importing and things like that. So what you can do now is go through File, Email, Import, and then you'll be able to add that straight into the patient's file. So we're trying to look at ways of obviously where you're working and how you're working. So if you are currently going in and scanning things, and that's a way that your practice has obviously been doing it for the last 10 years or whatever the case may be, this is just a new process that might be a bit more simplified that you can sort of use if that's recommended throughout your practice. So you can sort of have a discussion and things like that. So the other one is obviously doing the immunisation air. So Grant will definitely go through this in like full detail. But what I've done is I've tried to make a slide up so that you can share it with anyone else that didn't attend these sessions as well. So it's a guideline from within the practice that you can have. So you can either print these out, have a shared document area that you share with the team, and they'll be able to access these. And these are good training manuals as well for any new starters. So I've also tried to add different areas of information in regards to new information on like air and stuff like that. So this is obviously criteria that you can sort of go online and find yourself, but I've tried to add links and tips and stuff in here just so that, if you're not 100% sure of the changes and all those sorts of things, that you have access to that information as well, so that you can obviously choose what the recommendations for your practice will be. So as I mentioned, obviously checking to see if you are on the 4.3. If you are on the 4.2 currently, support after the 5th of December will cease. So I have added in how to get that access to update and all that sort of stuff as well.
Now, on that note, Kylie, is it us stopping that support at 4.2, or is it the government requiring us to stop supporting the 4.2?
Yep. So basically, this is in regards to, if you read the bottom line, basically the vaccination data already submitted to AIR. So we do need to have that based on, obviously, if you're not submitting to AIR, then you probably won't have to upgrade potentially. But if you are, then that's going to be a criteria for your practice that you will require that upgrade.
So just to reiterate on that one, it's not necessarily Medical Director Telstra Health not supporting 4.2. It's a case of that if you do AIR uploads, you must be on a compliant version, and the compliant version is the current version, 4.3. There will be a 4.3A update coming out close to that date as well, some features in there and some changes in there as well. But certainly and if you aren't a site that does AIR uploads, and there's many sites that don't do AIR uploads, but I guess if you're talking to nurses, you probably are doing AIR uploads, then certainly make sure you have that 4.3 in before, probably I'd say before the beginning of December, so you can make sure you don't have that last minute rush like everyone else will do. Charlie, back to you, mate.
So the next one is the floating progress notes. So this way, depending on wherever you are within the patient's file, you don't have to close things down to go add to the progress note or try and remember what you're doing throughout the consultation with the patient. This is just going to allow that easy access. So I've tried to sort of just, you can turn it on, turn it off. It will only show when you're in the patient's file also. So if you do close out of the patient's file, you will still have, the waiting room, but the tab next to where, if you're already using the mini waiting room, it's basically the same sort of little pop-up, but you'll have a little tab at the top next to the mini waiting room, and you'll be able to click across, but that's only once you're in that patient's file. Okay, so if you're used to using the mini waiting room, obviously it's going to be a breeze getting that up and running. If it's something new, obviously that might be an adjustment to your workflow. So if you are currently already using the shortcuts down the bottom in the patient's file, where you can have like your medical, like any sort of medical template that you're currently utilizing, previously on the other versions you're only entitled to 3 and 2 websites. Now we actually have, as you can see, 10 in total, and you can decide whether or not you're going to use them as letters or URLs. So depending on what's based on your work preferences and what you need to use every day, that's going to make that a little bit more efficient for you as well. And now you don't have to go into the tools and options. So I know like some people have their accounts locked down depending on the practice and, what support levels that you have. This has made it a lot more easier because you don't need access to that. You can just basically jump straight in and start adding them in straight away. Okay, so if before you
those are individual settings too. So basically whatever changes you make to your particular 10 buttons, 3 buttons, 5 buttons, whatever it is down the bottom there, then it changes just to your profile. You're not changing it for everyone else in the practice. So if you're worried about putting down there the latest, handbook for injectables, drug handbook, or whatever the case may be, then it's not going to affect other users. So it's purely just for your profile. If you change computers, that should also change with you, but it doesn't affect other people in the practice. Just worthwhile pointing that out as well. Sorry, Kyle.
Yep, and if you obviously want to share the ones that you've set up, you could potentially do a screenshot of yours using the snipping tool and just share it with the team. If you want to sort of help set them up, especially if you've got a new starter, they may not know which ones you're currently using at your practice and things like that as well. So it might be handy for them to know, because at the end of the day, your practice may be using user-defined templates, and then others may be using the supplied ones. So depending on your practice, you may be using different things as well, but I know that obviously a lot of practices are trying to align that everyone within the practice is sort of trying to do the same workflows, or at least create that same process across the board. So I'm not sure about everybody. Like, obviously it is up to each individual user whether or not you're a shortcut whiz, or you like to use your mouse, or your keyboard, depending on how you work. Rather than me adding in just the new ones, I've just done like the keyboard shortcuts for all of them. This way you can sort of utilize them if you need to. If you work without them now, you don't have to, but these are definitely going to assist with your workflows and things like that as well, if you are interested in using these. I've just added there's 3 lots of them there. So there's your letter writer ones, your clinical ones, and then your front page as well. So another one is that if you are adding in the next of kin or emergency details, so you'll notice that when we go in to the patient demographics, you'll be able to see that we've got that personal detail tab at the end, and you've got your next of kin or your emergency. So previously, if the information wasn't added because the patient didn't give you the information, there was no spot to be able to put in that you obviously collected the information or tried to. So now you're able to tick that box saying no emergency contact provided. So for accreditation purposes and things like that, it is good to make sure that one, your practice looks like you're doing the right thing. Obviously, good data in means good data out as well. So trying to obtain this information is the benefit of the practice, but at the end of the day, you can only collect the information that the patient is willing to provide as well. So this is going to assist with those sorts of scenarios. So the next one is definitely the adding in all of the gender labels and things like that as well. So pronouns and all that. So this way you've got access to that within clinical and Praxoft. So the changes have been made to both systems. Currently I'm only going through the clinical side of things, but I have created slides for both the clinical and practice management software as well. So the next one is that if you are in a patient's file and you're going through and looking at the holding file, you are now able to view the patient that you're in rather than the full inbox with all of the correspondence. Okay, so that will make things a little bit easier. Obviously making sure that you're utilizing the filters, clearing those filters. If you can see there's one result showing and then there's 100 records, we wanted to make sure that we're viewing everything that potentially is in there, and if you've put a date range or anything on, but Grant will go through all of those sorts of scenarios shortly. Depending on the practice, doing your CEBDs and things like that, assessments, we've got different tools that you can utilise within the program, and obviously that again is up to the practice in which ones you use. So now with doing any of the scripts, we do have a new tick box here. Basically, this is going to show all the results containing the above test. So as you can see in the first search, we did get minimal search. So now we've got a lot more showcasing to the practitioners or nurse practitioners and things like that. So if you are doing any of those prescriptions, we're just trying to obviously give you as much information as possible for you to search through and have a look at the appropriate one for the correct patient.
Where that became a real issue was in the plant-based medicine area with medicinal cannabis. Certainly a lot of practices that are finding it difficult to put in whether they're looking for Royale or instead they have to put Tasmanian Botanics Royale. So the whole idea of that is to have that show that results contains above text. If you put in there just Royale in the previous edition or in 4.2 and prior, it would get you nothing because you'd have to start in with Tasmanian rather than with Royale. So that's certainly where that became a very big issue. Sorry, carry on, Kyle.
Fantastic. So the other one is once a prescription has been done, how to cancel or delete the e-script as well. So I've just sort of added in extra information. So in the other slides, we do have what the process is on how to send, but this was obviously something that we didn't have access to. So I've just added these in to, make those slides more complete. All of the
and a note on that, of course, it would only be relevant for nurse practitioners on this call. Generally, our nurses won't be prescribing. There may be nurse practitioners on the call, so certainly it's a shout out to them. If, of course, you're not a nurse practitioner, then you won't be able to do those prescription resends and that sort of thing.
So it is definitely based on the profile that you've been set up with and your roles of permissions and things like that as well. So this potentially is a new process. So I know that obviously a lot of practices do have their practice manager as their nurse as well. So we may also have practice managers also on the line. So I've tried to obviously add in as much information for both to try and make it as relevant as possible. So I know a lot of you guys do an amazing job, regardless if you're adding the practice manager role on top. So it's handy to know if you are going into areas currently or previously on the 4.2 and you then find that you're not able to edit a template or something like that, then you may find that if you don't have access to the roles and permissions section, then you'll need to speak to your practice manager within your practice to get them to update these roles for you as well. So
this would probably be the most common feedback we get from sites that go up to the 4.3 is this particular screen. All right, so we'll talk to it a bit more when we come back and talk about the managing recalls, because this is quite critical there when it comes to the recalls. You'll see on top right there in that little screenshot, clinical add recall reason, delete recall reason, and edit recall reason. All of those are grist to your mills as nurses. You know, one of the common things that you guys are dealing with is that recall list. You go through the exercise of tidying up the recall list, and then the doctors go through and add all their own recalls again, which is great. That's fantastic they do that, but only if it's appropriate to do so. So, of course, now how do we judge whether something's appropriate to do so? Well, if we've got individuals in the team that are good at it, well, we leave them doing it. If we've got people in the team that aren't so good at it, we try and counsel them and educate them appropriately. And if they don't listen to the educational counselling, then we delete the ability for them to make changes, I guess, at the end of the day. Not that we want to go down that brutal way, but there's sometimes you got to, especially with, I don't want to point fingers at registrars, but registrars have been known to make silly mistakes because that's why they're registrars. So in that respect, you know, you can go in and modify these things from, for example, data export privileges. Make sure you don't have data export privileges on for the inappropriate people in your practice. Make sure it's only on for people like principals and that sort of thing. You know, if you're a nurse, well, then certainly it might be up to your practice as to whether you'll do data export of data files and that sort of thing. You might or might not, but I think we'll talk to this a bit more when we come back into the managing recalls area, because this is really critical to that whole managing recall process. Sorry, Carl, carry on, mate.
That's okay. And the other thing is obviously there is an audit history and stuff like that as well. So based on, you know, depending on what you're doing within restricted files or whether or not you're in a patient's file that's not restricted, but you're not supposed to be in there because they're a family member, that is also accessible. So we do have audit histories and things like that as well. So we now have restricted access to patients' files as well. So this is basically, as you can see in that permissions section, that's where this will be added, and then within the patient's file on the demographic screen, you'll be able to see that there's new access restriction area. So majority of patients will automatically be, or everyone will be added as no restriction, and then you will then go in whether or not you're adding in the regular practitioner or users restricted. So if someone is to go in there, we can access that later on. So you'll add the regular practitioner at the top first, and then go through and follow the rest of the information as well. So I've tried to add like little tips and information and little shortcuts based on, you know, whatever the relevancy is as well, just so that you've got it all at one screen. So the next one is that if you are working from home, which seems to be a lot more regular these days than it ever used to be prior to COVID. So if you are having issues with like printer settings and all those sorts of things, I've added those in as well, just to showcase how you can go in and update those. I know this is also some areas that, you know, people don't really like you touching as much. So try to only come in here if obviously you do have permission to do so. Otherwise, you know, you may break something if it's not already broken.
So that's mainly pertaining to just that past screen back there, if you wouldn't mind, Carlos, just go back one. That store printer settings there on that right there is mainly pertaining to terminal session sites. If you have a terminal server, Quite often practices will remote in using terminal services, and that caused issue with how the printer would print. I don't know if it's going to be much something that you guys would do, as opposed to tends to be more of a doctor thing, where they're printing out results or printing out prescriptions to take to aged care potentially. Maybe you guys do it a bit. You'd certainly access medical director, no dramas if you wanted to, but that's mainly dealing with the doctors. Tend to do that a bit more. And practice managers as well, to be fair, but the nurses, you guys tend to not hassling you, start and finish, and don't tend to come on remote. And if you do, great, but it tends to be more the doctors tend to do it a bit more. Carry on.
You may have already noticed that we also have a new option that when you log in with your location. So if your practice does have multiple locations, you are now able to select from the location. And for the practice managers, basically, if you are adding another location, I've added in each of the steps on how to add it in clinical, and then go through and add it into Praxsoft. That way, you will need a new user ID if you're going to be setting them up in Praxsoft, rather than.
But you won't need a new license in that respect, right? Especially as nurses. As nurses, you don't need licenses as such. Clinicians need licenses. They're a licensed user in the software. Generally, it basically goes off their prescriber number. All right. So if you've got Dr. Kylie Goodwin and she's in the system with XYZ provider number, you add her in again as another user in Medical Director with the same prescriber number, and it will pick up in the background. It's the same prescriber number and not use up one of your license allocations in that respect. So just worthwhile picking that up. Okay.
Definitely. And if you were wondering how to actually go in and add a location, so obviously it's good enough to be able to see it on the main screen, but how do you actually get there in the long run, which I was finding quite interesting with some of the terminologies. So that's why I've sort of created this documentation so that you can actually understand each step and what that next workflow would potentially be. So potentially you'll just come in here and go through and actually add in a new practice location. Okay, so all of those stuff will be sent to you shortly as well. And then, as you can see, I've also gone
Kyle,
through.
if you wouldn't mind, just go back to that previous screen for me for a sec.
Yeah.
Just want to note there, you see there probably halfway down that list, a really important one if you haven't come across it already. Lock on into activity after X minutes. This one drives new users in 4.3. Batty, where'd you go? Come back.
Sorry, I was trying to highlight it, but didn't want to highlight. I was like, whoops.
What are you doing to me, mate? So you'll see there in the right-hand screenshot down the bottom left of that bottom screenshot, you'll see there's lock on activity after 15. Generally, I come across a lot of practitioners go, I want to make it never. I go, look, hang on, how about you make it like 90 minutes? 15 minutes is probably a little bit short. I think 90 minutes is on a bit more of the generous scale. I wouldn't make it so it never locks. I think it's a bit dangerous to make it never lock, but I think 90 minutes is a fair, obviously we do this with the clinician's input. The clinicians are going to say, make it never lock. Doc, how about we make it lock after 90 minutes? Or, just be a bit more sensible about that. This is an e-prescribing compliance issue, EPP, where in the software we had to be compliant with that legislation, which makes it so that we can, lock the software after a set period of inactivity. For whatever reason it was chosen as 15 minutes as the default. I'm not going to go into whether that was right or wrong. I wouldn't dare. But certainly when it comes to, changing that, I'd recommend going into there. Once again, as Kylie's indicated there, you go into the tools, options, practice, you edit the location, and then you put down there that little 15 minutes, 90 minutes, whatever the case may be. Personally, I think 15 minutes is a little bit too short. I would probably make it maybe 60 minutes, 90 minutes, something like that. Sorry, Kyle, carry on.
Like, obviously a good rule of thumb is also to lock your computer once you leave it, having it accessed. So at the end of the day, with the audit tools and stuff like that, they're only as good as, if you're logging anyone else in to your computer and letting other people use it, then, if something then comes back, your account's the one that's going to get blamed, not somebody else. So,
it's the Windows key and L. All right, and don't do it now. So don't suddenly I see everyone looking down the keyboard like Cara go, well, what does it do? And suddenly everyone disappears off the screen. So don't do that, please, because you will lock your computer. All right, the Windows key and L, once again, don't do it now, do it later. Windows L will lock your computer. So as soon as you walk away, you know, if you've got a laptop, obviously close the lid, depending on what happens there when you close the lid. Some laptops will close and lock, some won't. So just Windows L, if you're on a Windows computer, 99.99% of us here in the call will be, whether you like it or not, I'm a Mac user, the Windows L will lock it. On that note, if you ever hit Windows D, it also shows you your desktop. So I often see people diving for the desktop going, how the heck do I get to my desktop? I've got this file on my desktop to show you, Grant. Windows key and D get you the desktop. So Windows L to lock, Windows D to go to your desktop. That's your small little Windows update for today. Carly, carry on.
I was going to say, what, no Mac Intel?
No, I'm not going to tell you the Mac keyboard shortcuts because no one here will be using a Mac, and it's not relevant to the conversation today. Let's not talk about Mac. So don't tempt me, Kylie.
I can't help myself. You got to have a laugh. So basically, next minute we'll get everyone in the chat saying we all have Macs. That'll be right. So if you have a Mac, pop it in the chat. So Grant has to tell you the answer. So basically we've got adding the nurses or the doctors different locations. So I've added all of the steps in there as well. So that way when you go in, you'll see that you've got the two different locations. So you've got here, I've just added a one just to sort of show, but we've got a sample one and we've got Bundaberg there. So you'll see that we've got like the prescriber number and then we've got the provider number. So in my case, obviously it's all fake data. So I don't actually have a real one. So we've just duplicated the information, but putting the correct information in is going to be beneficial for all of your letter write templates and things like that as well. So that whatever's printing is going to print from the right location. So previously, obviously, practices had pre-printed information potentially, which would then mean that, you know, you may have been finding that you didn't have to worry about that because that document was already created for you. But now you don't have to have that pre-printed information on there. You can sort of have those templates pre-set up. So that it's automatically going to pre-fill the correct information based on the location that you've logged in as.
Just looking at that window as well, Kylie, I see you've got there tick the PKI encryption checkbox to enable the encrypting of email correspondence. Please don't do that. All right. PKI is old school technology prior to NASH. NASH has replaced PKI. I don't think I ever came across a practice in my 17.5 years that ever used the PKI encryption checkbox. But certainly don't turn it on because so 99.9% of us won't have a PKI anymore. Recently, it was still active in Tasmania because Tasmania had some particular PHN-sponsored thing that they needed PKIs for, so they still had them. The rest of Australia should all be on NASH, so ignore the PKI encryption stuff because it's old school.
I will have that removed because I haven't sent through the final copy. As I said, I've been trying to go through this morning to go over everything just to make sure, but obviously good pick up there, Grant. Could tell me off screen, but you know.
I'm just telling to making sure we don't give the nurses the wrong information, mate. This is not about who's right and who's wrong. Let's get the right information out.
No problem. So we do have some really great new clinical smart tools that are available. So we do have a lot of new AI stuff coming out and providers and things like that as well. So we are requesting whether or not someone would be interested in becoming basically a beta tester. So if you are interested in any of the AI and stuff like that, definitely send us through your interest and we'll make sure that we can get that through to the right area.
And that email is really the hello@medicaldirector.com. That's for real. So that is actually a real email. Do send it through them.
It's not for flowers, but it is for if you're interested in beta testing for
Don't
AI.
ask for the flowers. Don't send an email asking. They'll look at me and go, "What the hell did you do, Grant?" But certainly, if you are interested in the beta program, then certainly you're welcome to have a look at that. I didn't actually get to talk, and I probably should have mentioned this to Barb and Tara yesterday about AI to our doctors that much yesterday. Although it was going to be the big topic, I just ran out of time. We are going to have AI in by Christmas, and so. Is what we're looking at this stage. I'm not going to say by that 5th of December launch because Murphy's Law or Sod's Law will dictate that it will not be in there by that date. So I'm going to say before Christmas. But the product team have assured me There are going to be a couple of different options there when it comes to service providers and subscription levels and that sort of thing, and also functionality in the software, depending on how much you want to pay them, depends on how much integration they have in their software, that sort of stuff. They'll still pay for what you get. So in that respect, AI will be in by Christmas. Apologies, Barb and Tara, for not actually saying that yesterday. I did promise to say it yesterday. I didn't because we ran out of time and I forgot about it. I'm just thinking about it now. But certainly, this smart research is probably one that I did want to actually mention to the doctors yesterday, but I did run out of time, as I say. And this smart research is going to be really good for the CPD side of things. As we know, CPD for our clinicians has changed quite significantly in the last period. And that, you know, the CPD has in some ways more than tripled the amount of things that they have to document. I'm not saying they wouldn't do the learning, it's just how much you need to document. And that's certainly that smart research opens you up into, I think it's called Prax Hub, just off the top of my head. And Prax Hub basically then can provide you content, which they are able to then track the reviewing of that and provide you questions all in line with the appropriate CPD accreditation reporting requirements. And that smart research tool is available to all users. And of course, our nurses on the call will be, I'm pretty sure, do CPD as well. So that could be useful for you as well. That's free. I signed up that yesterday. It was good. It's a nice process. It's got some information there. You just highlight what particular areas of interest you have. And then they'll present you topics or, you know, information sessions on that. They might be half hour, hour and a half, depending on what particular level of information is. Quite in depth. I was quite impressed with it yesterday. Kylie, carry on.
Yeah, I definitely think that obviously if you're already reading it as a part of your day-to-day workflow, then, you know, you should be getting those points on that rather than having to do this outside of hours when you've already gone through it. So having that at like a tool within your program is just going to be a game changer. So I have added the link on how to set that up and all that as well. So if you guys are interested after, you'll be able to just come straight on here. We do have a new cyber clinic tool coming shortly as well. So basically based on your practice, whether or not it's beneficial for you guys as well for mental health, the patient does get linked with a specific person based on their criteria, and that's Australia-wide. So rather than it getting like specifically giving it to someone in your local area, it's actually going to match the patient with the appropriate person as well. So, and if the patient either finds themselves that, you know, they're not paired well or whatever the case may be, it may be time issues or anything like that, they can actually switch over to another person automatically without having to go back to the healthcare provider to get that done, and the patient actually gets an SMS when they're in the with the healthcare provider, so they can actually see that action happening as they're in there as well. So that's really beneficial. There is a cost to it. Quite often
it's worthwhile understanding what problem we're trying to solve here. All right, what are we trying to solve with the Cyber Clinic widget? All right, and the sidebar or the smart bar add-on. Basically, we know that mental health is becoming a really big issue in Australia and around the world. And that mental health, you know, it's hard to get access to the appropriate mental health for the individual. All right, whether you're looking at psychiatric, psychological, you know, counselling, whatever particular level of mental health you need, this cyber clinic is helping you as nurses and you as a practice to be able to provide access to that very important avenue of mental health care, and making that a bit easier and taking some of the burden off when the client, you know, or the patient comes back and goes, look, I went and saw that Dr. Kylie Goodwin and she wasn't much chop, mate. I didn't like the way she spoke to me. I want another doctor. Can you give me another psychologist, please? I just didn't gel with them. That's fine. That's all done through that particular cyber clinic link that gets sent to the patient. The patient can change that. And it all gets done through that little widget. We actually got a presentation from their company a couple of times in the last few months, and I've got to tell you, it's quite impressive. We did release it about 4 to 6 weeks ago. We put it out and a whole stack of clients, as in terms of practices, jumped on board. It crashed the poor cyber clinic server. We had to pull the widget from everyone. Where'd the widget go? It was really good. And the problem is now the cyber clinic guys are bumping up their servers, which they've done in the meantime. And the cyber clinic will be relaunching in the next couple of weeks. And I dare say we'll send out another marketing advice just to follow up saying, yes, we did relaunch this previously. Just due to demand, we did have to restrict access to that. In the meantime, we have improved that and should now be able to have access to everyone doing that. So really can't say enough good things about Cyber Connected and the mental health challenges that we face in Australia currently. Kylie, carry on.
I have added their email to the bottom, so if you are interested, just even if you shoot them an email just saying that, you know, once it's up and running again, please let us know. That way they'll just contact you once it's ready. So that might be an easier way than going back into the sidebar to try and see if it's still there or when it comes back. So that might be a quicker, easier way. Another one that you may be doing is the TGA reporting. So I have had a lot of practices not really sure on how to find the information. So I've given you two options here in regards to how you can do that or how you can access that. And then it is obviously not a 4.3 initiative potentially, but it is something that people were asking. So I thought it was relevant to add in here as just an add-on. So this one, I'm just going to jump past that. So we also have the 4.3 in Praxsoft, but I probably find that we'll probably go through this more in tomorrow's meeting. So you may be also attending that one. But as I said, you will get access to all of these slides anyway. So what I'll do is I will give you now back to Grant, and then he'll be able to go through and showcase how all of the other features work in the system. But as I said, everything we will be going through, there will be potentially a slide on in another slide deck.
Thank you kindly. Hopefully everyone's now seeing my screen. We should have Anna Andrews, select patient from list on the screen. All the patients you'll see in my system are fictitious. If there is actually an Anna Andrews that you know of, please give my best wishes. Hoping that we will cover 1, how to add personalised templates for care plans, and 2, holding file permissions, how to set nurses to move a file and patients record. Okay, the second bit on that one, the holding file permissions might have an issue with regards to moving it around, but we can check that. Adding personalised templates, yet we can go through that, that's fine. Okay, so in terms of what's on that list currently, what's on my select patient from list, this is picking up my Praxsoft waiting room. So if you're ever wondering where is this list coming from, it's actually coming from your Praxsoft waiting room. If you go over to your Praxsoft waiting room, you'll see there's Anna Andrews there. Okay, so if I then just go here, open this patient, going into the clinical record, we did talk yesterday about the prompts and how much it drives clinicians balmy, and I don't blame them for that. But the prompts are actually there to assist. Certainly I would recommend, potentially customizing the prompts that you get when you're coming into the software. I wouldn't recommend turning them off, but many practices do, but I wouldn't recommend it. Certainly for your admin staff, your practice receptionist, your practice manager, yeah, I have no great drums if they turn off the prompts, but you guys in the nursing world, the doctors, I'd rather you customize rather than turn off entirely, and we'll go through some of that in a sec. So when we're coming in here, of course, getting prompts about, happy birthday, and I'm currently coming in as a doctor, forgive me. So what I'm looking at now is our summary screen, all right? Most of the users in the call, I dare say, are probably starting in here, because this is the out-of-the-box setting. When you open up Medical Director for the first time, you're a new user or you've never changed this setting, when you open up a patient's file, it will go straight to current RX. Right. 32 years ago, when Medical Director was written as software, it was as prescribing software. So that's why out of the box it comes into this screen. Makes sense. Generally speaking, all the people on this call are generally speaking they're going to be a nurse or a nurse type role. I would strongly recommend setting your particular opening screen into this screen, the summary screen. Let me show you how you do that. Now jump out of the patient file. You've got to jump out of a patient file to make the setting change. Go into the tools area and options. All right. Go into the clinical area. All right, and you'll see here on the screen here, open patient in. All right. Most of us will have this setting to start with. All right. In terms of the summary, as I say, summary, in my opinion, would be what I would demand all nurses start with. All right. In terms of the admin team, I'd put them in progress notes. If they're purely your practice manager or your receptionist, usually what they're going in to see Medical Director will be is, when's the last time you saw the nurse, or when's the last time you saw the doctor, or something about the last consult or previous consults, which is why for staff members, as in like non-clinical staff members, progress notes is probably the appropriate one. But please, for nurses, make it summary. All right, do that for me, I beg of you. Reason being is I also like to see doctors make summary there. Doctors, fair call, they generally, they're looking at current RX, they've got a different way of using the system to us mere mortals. So in that respect, the summary side of that for us would be a strong option there. I've also got this option here as well, the mandate entering a reason for contact for each consultation there. That's quite often a common one that the practices would like to see their clinicians putting in reasons. I haven't done my usual spiel about the quality in and quality out aspect of clinical software, regardless of whether it's Medical Director, ZMed, Genie, Best Practice, whatever it is. The quality of the software is only as good as what you're putting in there. So if you're not putting good quality data in, you're not going to get good quality data out. The reason our PHN is here is to help us understand how our clinical tools affect our actual community. All right, and so if we've got good data coming in, then we can make sure that when we're looking at that data, we're making good reasons and good outcomes from that particular information based on good data. Whereas if it's not good data, then of course we're not going to have good information to be able to make judgments from. So mandate entering a reason for contact for each consultation. Please, I'd recommend that one. I have actually come across a practice many moons ago that actually did use the acupuncture page, so I'm not going to hassle them, it's still there. But as I say, just make sure that show summary page is on. So if you've gone to the summary page and you don't have the show summary page on, you could have a problem. So make sure that show summary page is on, please. And then we hit save on that. And that's the major change for that. I will actually talk to a couple of other options in that particular area as well while I'm there. In terms of in here, Kylie's already indicated that store print settings there. I don't think that's going to affect most of us on this call today. Progress notes is the other important one there. Prompt to for Medicare item number is a good one. Doctors usually will drive you mad on that one. Don't you guys as nurses turn it on, because you'll get prompted for Medicare item number and you don't need to be prompting for a Medicare item number. Doctors should be the ones getting prompted for the Medicare item number. Whole idea of that is if they have that on, if they go into the software, into the progress notes and hit the Medicare button, put in the item 23, 36, whatever it's going to be, then it will go across to Praxoft automatically. If they haven't put that value in, then that particular one will pop up and go, what Medicare item number you want to charge. Have a chat to your doctors before you turn that one on. That one can cause friction, let's say. All right. And in terms of other ones there, that one we were talking before about that lockout, to when the doctors get locked out of the software during activity. That's here in this practice area there. You'll notice I've set up 2 locations in my system, just for training purposes, to see how it works, just to show people how it looks. So in that respect here, if I want to make changes to either one unit or another, then I can edit that. And you'll see down there that I've got there 999 or 9,999 hours. Let's do and follow my instructions there and change it to 90 rather than 9,999. And of course, you would have the appropriate information in there, not the undefined ones like I have. Bad Grant. And this is normally where you'll also find your NASH certificates. Just keep an eye on that in the corner of your eye every 6 months or so, because that will expire, I dare say, in about 2 years. It's probably going to be down to about a year now, I dare say, because I think we all did an update in about 2023 from my memory, when we all went to the SHA-2 or something like that silly. But of course, once we've done that, we hit save, and of course update all the appropriate values in here. I'm not an aged care residential service or whatever, so I'm just going to go save at that stage. As I say, that's where we'll make changes to that lockout. Okay. All right, so coming back into the patient's file. All right. And in terms of making changes to those prompts that you will get, in terms of those option changes in here, you'll notice when I come into the options area inside a patient's file, I get less options up the top here than I'm outside the patient's file. When it comes to the prompts, I can actually do prompt adjusting from inside the patient file. Don't just go and turn off the enable prompting, please. Don't do that. That is, as I say, for your practice managers, for your reception, yeah, turn off the prompting. For us in the clinical world, please go through and update what's appropriate. If you're doing childhood immunisations, please turn on the childhood immunisations prompt. It's there to help you. All right. The whole idea, if it doesn't pick up the right amount of prompts in the software from the immunisations area, it's going to prompt you and say, hey, do you want to update the childhood immunisations? It's there to help. All right. Prompts do drive people mad, but sometimes they're there to help. So in that respect, turn on the appropriate prompts for you, all right, because there'll be some nurses on the call that are doing immunisations, there'll be some nurses on the call potentially aren't doing immunisations. So once again, just customise these prompts for what's appropriate for you, okay? Did save there? Okay, so when in terms of this main screen here, if we're coming into the software looking at this, I get a restricted view on what's happening with the patient. All right. To have a look at what's going on with the patient's history, I'd have to be going into the progress notes, have a look at when's the last time we saw them. I might be going in, having a look at the letters. Did we do any referrals? I might be looking at documents and seeing if we've received any reports back from specialists. I might be looking at results. Have we received any blood tests or, you know, barrages or anything like that? Have we received any particular images or something like that back from? It's quite hard to create an overall holistic view. The summary screen gives me a much better option to do that. Here I am seeing family history, social history, past history, immunisations, medications, and preventative health, which should be all grist to our mill as nurses. All right. We'd love to see our doctors going in and updating family history and social history. Probably not going to happen, let's be honest. The reality is that, you know, quite often the burden of data quality and data maintenance falls upon the nurse. Sorry to say. All right. And if it doesn't, great, keep it up. But if it does, well, then we need to make sure how we're doing this. Simply when we're coming on this screen alone, here I'm keeping family history and social history up to date. I can see here that I actually updated this family history yesterday because I put my initial there and say, Dr. Diagnosis, 6th of August 2024 was the last time I updated this information. I couldn't tell you the last time we did that update on whether they're doing bowls on Tuesdays or Thursdays. No idea when this is updated. It's actually done yesterday, but I know that. But the whole idea of this is good quality data in. I know when it was last checked. I can check it when it's appropriate. The last time that daughter lives in Perth was 2020. I might go through and ask that question again. How's your daughter going? Still in Perth? Oh, no, she's moved back. Oh, great. Well, we might put her in as a next of kin or emergency contact or whatever the case may be. All right. So in terms of landing on this screen, good recommendation to land on this screen. Past history, try and tidy up a couple of things on the past history. Don't try and tidy up the whole thing. Just choose 2 items off the past history list to see if they're relevant. All right. Is that immunisation from 2012 still relevant? If it's not, double click on the entry. It will take me into the past history area. Right click on that particular item and either edit or delete as appropriate. All right. As Kylie mentioned there, in terms of the results and letters and documents, all of those 3 are combined in the correspondence area. Right. Some practices don't have the correspondence area. There is an option in there to turn off the correspondence area. If you don't, you might want to turn that on because as I say, I find it quite useful if a report has come in and it's been inappropriately filed in the letters area as opposed to results or as opposed to documents. Then the correspondence can be quite useful. I even had a practice just I think probably last week saying to me that there was items missing from the correspondence list. No, there wasn't. What it comes down to is that you can have different screens sorted in different ways. What I mean by that is, if I look at my letters screen, if I click on my date created, I now have a tiny black triangle created next to my date created field. And that means I'm sorting this screen, the letters screen, by the date created field. Now, the other fields in this screen could be sorted by different values. If I go have a look and make this preview down the bottom, right, so I can see a lot more information up here. I can say it's actually date collected is the field that I'm sorting on here. So potentially if the date collected and the date created are different, I may get a different order of presentation between this tab and this tab because they're sorting on different things. All right, and that's exactly what was happening at that practice. Once I said, right, let's sort everything by date created on that screen. Let's sort everything by date created on this screen. Suddenly everything matched up perfectly. And the way we check that was by using these filters. So Kylie has already mentioned the filters there before. These are not new. These have been around since a long time. All right. These came in 3.14 version, if you're paying attention. The whole idea of these particular filters is that it's basically picking up the value types in the screen. All right. So in this screen now, I've got types of documents. I've got types of letters. Now, if, for example, I just wanted to show the letters on this screen, I could just uncheck the document, go, OK, and that will then show just the letters. All right. And when we saw before about that, we've now got highlighted columns are filtered here. Now, I don't know why they call that dark grey thing highlighted. I don't know what you'd call it. I mean, highlight, I guess, makes a fair comment, whether you call it a highlight or something else, whatever. But that particular highlight may be buried somewhere over there on the right-hand side, and you may not realise that you're getting filtered results. All right. And the whole idea of that is that if you see this cleared filters button there is black, Unless you're expecting the filter to be on, turn it off. In other words, hit the key filter button. If it's grey, you've got nothing to hit. You mash it all day long as you like. There's no filters on. You're fine. You're cool. All right. But if there is a filter on, right, you might well find that you are missing the information that you require. All right. And you see there how quickly and easy it was for me to incorrectly sort by type as opposed to sorting by date created. Just be aware of that. It's a common thing I do see that goes wrong in practice. And people start saying, medical director's gone mad, Grant. I don't know what you guys do, but you guys do wacky stuff in the program. And it's just somebody accidentally left-clicking in the wrong place on the screen at the wrong time. Right. So also be aware that preview there. This preview's been around, once again, probably similar time there. It might have been 312 when we came in on for that one. But certainly whether you put the preview to the right or the preview to the bottom or the preview to the full are all options for you. Generally speaking, I'd recommend when it comes to these screens, your letters are going to be date created, subject, recipient, description. Have it preview to the right. Right, so you'll see their preview right as it is now, and make sure you have your zoom at page width. Okay. All right. In terms of recording the values that you need to record in the software, quite often people will go into the progress notes there and type down I want my blood pressure to be 120 on 85. Don't put the blood pressure there, please. You'll make it go from 120 over 85 to probably 130 on 90 on you, and you'll give me a heart attack. Don't do that. Where we want to be going is into the examination area there. All right, click in the examination area. Put that value in here. All right, then go save, and then it appropriately brings that back into my results, into my progress notes appropriately. Gives me much nicer formatting, and it's being stored in the appropriate values in the software. And if I need to, I can go through and do an analysis in gaps in care by Polar or PenCat or however I want to do it later. All right. So please make sure you put your examinations and measurements in through this panel here. All right. I generally don't find people doing the drawing on the diagrams that much these days. You're welcome to do so if you do draw on them. Like if, for example, if I put in here that the patient had some recession and an audible wheeze, and they had a SpO2 value of 93, and we had a little bit of sepsis here or whatever it is, and then go save. If we do a change there, you'll see it's got this respiratory bitmap changed. All right. I've been asking for a long, long time to be able to get the image into here. If you change the image, that's what's changed. All right. It gives you a value here saying respiratory bitmap. What that means you then need to do is go into the examination area, go into the respiratory area, and you'll see the diagram from that day. Okay, just be aware of that. So the take-home message here, when it comes to entering values into the examination area, please put them into this area in here, all right, or into the toolboxes as appropriate. So we have at the top here our toolbox as well. If we're looking at, say, our blood pressure, once again, we could do it through the examination area, or we could do it through the toolbox, and then we'll go through and bring in the appropriate values, differentiating between sitting, standing, lying appropriately. So in terms of this, you'll then be able to put the values into here. You can graph that as well and see how things are going over time. Some people would use that, and quite often the nurses will be doing some of that counselling, is to look, you know, when we had our HbA1c under control, look how our blood pressure came down. Look now that we're no longer taking that medication, our blood pressure is going up, and you can then, you know, visually demonstrate that to some of your clients or patients, and can be useful for doing that as well.
Sorry, Grant, just got a question in the chat. We just have, what about multiple BP readings in the same appointment?
Yeah, you should be able to do that. What happens with that is it doesn't actually come into the progress notes. If you do multiple blood pressures, it doesn't come into the progress notes as such. It brings in, I think, the first value you put into the progress notes, hence why it's useful to go into the blood pressure area into the toolbox, and it is then tracked longitudinally with the time there. All right, so if you are doing multiple blood pressures because a patient may be having a cardio infarction, you know, and you're checking it every 3 minutes for a blood pressure reading for a sudden drop or a sudden increase or whatever, you can certainly enter it into that toolbox, and it is then listed by time in that toolbox area. So I write in progress notes, it only shows 1 BP. Yeah, I understand that. I'd still, as I say, the problem with that's going to be is it's not going to then track in the graphing, which is fair enough. I won't argue with that, Kate. I get it. But certainly you can do it through the toolbox. It does show in that way. All right. In terms of, I think we've got that recording measures done. I think we're under control for that one. Any other questions on recording measures? I probably should talk about, because I got stuck yesterday on the cervical screening one, how to manually add a cervical screening, but we'll talk to that in a second. Well, actually, we'll talk to that because I've got that further down the list. All right. So in terms of recording immunisations, going to the immunisation areas, as I say, this is giving some warnings. This is our sample system. Hopefully you won't get these errors. Please don't get these errors. In terms of what's going into the system, simply you'll see at the top here, we've got practice immunisations and we have immunisation history. All right. That immunisation history will give you where your AIR information has been recorded in there, and that will go into there. In terms of recording information in here, you can either right click on the screen, recording counter, hit the plus button, hit the F3 button, which is the general add button wherever you are in the software, and it'll go through and update accordingly. So if we just do recording counter, that will be the screens. And so the main difference here is this new one here is the main changes between the old immunisation system and the new immunisation system is the tracking of the vaccine type as to whether it's Commonwealth, private, state, etc. All right, and probably an important one, and this goes back to a couple of years ago, make sure that if you have an immunisation that you wish to upload to AIR, just out of the corner of your eye, just make sure that send to AIR button is on and ticked. All right, there was a while ago, and I can't remember, a couple of years ago, where we had a bit of a bug where it depended on how you added the immunisation. It wasn't being uploaded to AIR. We fixed it many years ago. It's all good. That's why I just happened to mention, just make sure the send to AIR is on, because the reason was that if you'd actually happened to notice the send to AIR was off and you ticked it on, it would solve the problem. It was just actually a default setting that was the problem. All right. In terms of, I don't think there's anything else we need to talk about in the recording immunisations. Anything else? Anyone questions on immunisations? Bring them in chat and I can certainly answer them. It's all fairly self-evident. As I say, this particular one will be your practice immunisations. This tab here, the immunisation history, will be your AIR record, and pretty much that's where it goes. Most people aren't doing medical exemptions and vaccine trial history, but if you are, then certainly some of those tabs appropriately. No questions on that one. Cool. Okay, recording cervical screening. Usually a cervical screen is coming in from the holding file. Gives me a chance to actually highlight one of the things that I brought into the software, which I'm very proud to say, which is normally when we did a holding file here, actually having the ability to use that filter that we talked about before. This particular option here to filter the holding file for the current patient effectively just opens up the holding file, but just puts a filter on for the patient. That's it. That's all it did. So pretty much that's a little function there. I won't show it now because I don't actually have anything in the holding file for this patient. So I'll go all patients. We'll select in here and I've talked. What happened there? We're good. We're still here. So when you've got this multiple entries here, if you have multiple entries for diagnosis or Kylie Goodwin or Grant Smith or whatever, some practices actually do want to keep multiple entries. I actually was in practice recently where they did want to have the 3 entries for Dr. Grant Smith, because some of those were for their urgent care clinic results and some of those were for their in-hospital results for their stuff at the hospital, and some of the stuff is for the practice. So you just shouldn't make an assumption of saying just sticking all together, because the doctor got cranky when I did that. But if you do want to join them all together, the way you do that is highlight the multiple entries for the diagnosis and hit this little chain button down the bottom left, which will then link all those entries to that particular user in that list. So rather than having to select 3 entries for Dr. Diagnosis, they just select the one on future and they come in and away they go. So let's hit OK. So normally what we're doing at this stage here, if we have a cervical screen result coming at this stage, normally what we'll do is we'll right click onto that and we would then go copy to record cervical screening result, which is the normal flow for this. If, however, the patient in the rare event does bring in a letter or bring in a paper result, which is quite possible, depends on how you're going to do it, because if it does come in through the holding file, it still may well end up in here anyway, because that's may well be the way the reception is scanning in. If it's not, and you literally need to do it a bit more manually than that, then what you can do is come into the cervical screening tab and right click and go new item and record accordingly. All right. At that stage there, put in the appropriate information, put in the result as appropriate, and record information as required. Okay. In terms of accessing that list, if we jump out of the patient's file, oops, because I've turned that prompt on about the Medicare item number, this is what it's now doing every time I'm coming into the software. So remind me in a sec to go in and turn that option off, because it will drive me mad in a minute, which is why I talk about you've got to just make sure. This is also the one for the reason for contact, because what we want to be doing is making sure when we're in our software that we put in a reason for visit. Now, if I don't put in a reason for visit, this pops up. And I should be putting in there what's the reason that was there. Now, if you're wondering where this list is coming from on the right-hand side, it's coming from the patient's past history. Right? To be fair, it does say at the top there, existing past medical history items. It is trying to make your life easy and say, well, the patient previously has had immunizations. The patient has previously had upper respiratory tract infections. If it's not pertaining to that, do we want to make it pertain to something else? Pick from the list, please. Do not, repeat, do not, and I'll say it a third time, do not select free text, please. All right? Because as soon as you hit free text, and I know you might say me, Grant, but I can't find the pain in my upper left knee on the list. Okay, fair enough, I'm not hassling that. Then just go pain and try and get as close as you can, but not in the free text area. I want to go to the pick here, and I go from pain, and then choose from that particular list as best I can. All right, and at worst case scenario, just select plain, all right, and choose left and put in a comment if needs be. Okay, hit OK. That's then going to record that reason for visit for that was pain. All right, once again, please don't use the free text area for that. Reason being, as soon as you put something in the free text area, Medical Director Clinical has no idea what you typed into that area. It's got no idea what you typed. So if you typed in there the patient is now diabetic, and you've done that through the reason tab here, and you're putting in here that they're going to be NIDDM or whatever the case may be, it means nothing to the software. It really means nothing. Whereas we do it from our pick list, that will pick up when we're doing, medications, when we're doing our medication checks, when we're doing our interaction checking. It's going to be doing all that checking for me if it's from the pick list. If it's not from the pick list, we're in big trouble. Now, I know we're fast approaching Christmas, and if you are looking for some Christmas work, in terms of in the software, not actually going to getting some more bursting elsewhere, in terms of if you want to go through and tidy up all those particular coded lists, you can do so. You do that from our desktop. We go into our Medical Director maintenance area, and you go into the database tasks and common. And oh, my apologies, we'll go to this one here, to the Medical Director Clinical, and go to Diagnosis Coder. All right, we will be asked to log in, which is appropriate to do so. All right, and that's where I can find all my free text entries in here, which I can then remap to an appropriate entry from here. All right, so if you do want to go through and do a quality improvement exercise, I know you've probably got lots of things to quality improve in your practice, but in terms of if you do want to go through and you've had particular doctors that were culprits for doing free texting or whatever, or you might have had colleagues who just militantly went, I'm not going to ever code anything, whatever, you can do it from here in the Diagnosis Coder. This is one of those ones where it's just one of those maintenance cleanup things, and we'll talk to a little bit of that coming back into here when we're going to do our recalls in a second.
The reason, I'll just give you a bad case scenario. Years and years ago, I did have a doctor that was putting in like asthma, diabetes, so basically they never showed up in any of the reporting, and that's why it's so crucial to make sure that you're linking that, because if you're trying to get those patients to come back in and they're in those mixed lists, someone's got to go de-web that, which is a bit scarier than you would think. So that would be the reason why, if you're finding doctors aren't showing up in that list, spelling mistakes and all those other things that can cause drama.
And of course, if they're going from the pick list, then you're not going to have a spelling error. Whereas if you're going the free type, that's where you're going to get spelling errors, right? Spell asthma incorrectly or whatever it is that you're spelling incorrectly. So certainly picking the pick list makes your life a little bit easier in that respect. All right. In terms of, I might skip managing recalls and come back to that one, and I'm not skipping it entirely. I'll come back to it because I think recording social and family history and alcohol and smoking are relevant now, and we'll talk about recalls in a second. In terms of a good little tip when it comes to going into the software, into the patient's demographics area, wherever you are at the top drop-down areas up in here, you'll see that there's various items here like Control D. Or if I go over to here, you'll see F5, or you might see Shift F4, things like that. Now you might say, Grant, what are they? You're going to go, Grant, they're a keyboard shortcut. Basically, what that means, if I want to do a pathology request, and I dare say there probably won't be many people in the room that want to do a pathology request, then I would go Shift, and in my case, because I've got my keyboard doing funny things, I'd need to go Function, because you may need to go Function to turn on the function keys from being the volume up, volume down type keys to turn them into function keys. So I need to go Shift, and in my case, FN, F4, and it then brings up the pathology request. Now, I don't expect you to do that, right? I'm just using that as an example of where do you find these keyboard shortcuts? What are common keyboard shortcuts that you would be using in the software? It's up to you. I'd certainly find that 3 good ones when you're coming into the software. F2 to open the patient file and close the patient file. F4 to go into a patient's recalls. And F8 to go into letter writer. All right, 2 times 4 equals 8. All right, we go into F2 to open the patient's file. We check their recalls. We hit the escape button if we don't have anything in the recall. If we need to go write them a letter, do a referral, do a particular plan, or do a particular overseas letter or whatever, F8 to go to letter writer. Or, of course, we can use our fast launch buttons down the bottom right there.
Just got a question in the chat there, Grant. Hello, when I go to the medical director maintenance, I can't seem to find where to merge reasons for contact.
Good. All right, what you're finding there is if you're coming onto this screen, this is the screen you're coming onto by default, the maintenance task common. You may need to select on the left-hand side here, database task, medical director clinical, and then you'll see that diagnosis code up, right? Because as I say, there's different areas of that. For example, if we're doing patient exports, there's been a recent change as well that Kylie didn't mention in the enhancements in 4.3. I won't hassle for it. Is that when we do our export now in 4.3, one of the problems we had previously was that when we exported patient data previously as a XML or as a HTML, and I won't go into the complexities of that, is that previously it wasn't picking up all the patient's documents that were on the patient's file. And we used to go down the furphy, or I won't say furphy, we were taking the appropriate condition of it wasn't your data, it was actually the data of the specialist who owned that actual intellectual property rights, blah, 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 blah. I'm not going to go down that pathway today. Simply to say, if we go clinical, and there is now a PDF option, which is the new option here. Previously, we only had XML and HTML in here. If you use PDF, it's also then going to do a PDF drop of the patient's data, but also including all their documents and results. All right, whereas previously the XML and the HTMLs weren't picking that up, just while I'm in the maintenance area.
Just so you know, that one will be in the Practice Manager user guide.
Very good. So in that respect, coming back into here, going into the little shortcut at the top right here, if I double click in the area next to the patient's photo, just double click that, that will bring me into the patient details area. All right, and this is where we have that new access restriction. All right, whole idea of the access restriction was so that that if you have a country practice, it's very hard to be going to another practice that might be several hundred kilometres away. Now I realise we're East Melbourne. There will be potentially some people that may have a semi-rural status, and it may well be that you don't have anyone in the call that has access to use this, and that's okay. Just be aware that if you do have staff members in your database, that they don't want everyone in the practice to see that they've got issues with their nose or their foot or their hand or whatever, then in that respect, you can put an access restriction on here. This is a new 4.3 thing. You can also see the wall of shame. What do we mean by the wall of shame? I'll just go cancel on that one. And the whole idea of the wall of the shame here is that basically it will show you who has accessed what patient files when. Right, so we've made it so that you've got effectively a break glass function in here, but you can then also access that particular log that everyone in the software can see who has accessed these restricted files, and you can then make appropriate follow-ups with the individuals concerned. All right. Okay. So in terms of opening that.
Just had a little comment in the chat. Just location of the recall button is not as visible as it used to be, which I think is a shame for all clinicians who used to be prompted to address.
Fair comment. Fair comment. Fair comment. It was previously down here a little bit. We had to move some screen real estate around for the gender identity. So something had to give. Sorry, Chris or Judith. In regards to accessing the patient data, as I say, smoking, alcohol over here. Now you can of course cheat. When I say cheat, use it correctly, which is going into the smoking area here and click on smoker, and that will take you straight to the smoking area. So that's sort of cheating because it's a training exercise today. So of course we're going smoking there. Put in the nature of the appropriate responses, frequency, number of cigarettes, whatever the case may be. Same with alcohol. Alcohol being the audit C style. I'm not going to go down whether we should have gone down audit C or kept it the old way. That was something that my personal doctor raised with me many years ago. We chose to comply with RSCGP guidelines, which was to do audit C. It's fair enough. Okay. Any questions on measures, immunisations, cervical screening, social or family history, alcohol or smoking? Any questions on that stuff? If so, pop it into the chat and I will address it. Otherwise, I will move on to recalls because recalls is a bit of a hot topic. Let's go into recalls, given it has just been raised. Okay, in terms of recalls, generally there's a couple of parts to the recall process. One is the creation of the recall. One is the management of the recall. So creation and management. And within the management side, we've got how do we manage the recall, how do we close the recall, all that sort of stuff. Generally speaking, recalls are going to start 90% of the time from the holding file. A result has come in. We've got, oh, that's not good. I think we need to contact Tara about that blood result. HDLs are too high or LDLs are too low or whatever the case may be. We need to get in contact. And that's, of course, a doctor's judgment, generally speaking. Now, of course, depending on your practice protocols, I'm going to dive into my good friend's website, Katrina Otto, at Train IT Medical. I'd certainly give her a highlight in terms of her collegial attitude to sharing of data. Certainly recommend her website at trainitmedical.com.au, and there's the beautiful smiling face of Katrina now. On her website, she has a fantastic resource here in the Medical Director Free Resources area. And what I wanted to show you here was some of the templates around recalls and reminders and how we deal with correspondence management, because this is what we're dealing with now in terms of recalls. There are a number of different protocols here. I'm just going to open up the sample 3-doctor practice. Obviously depends on, there'll be some people on the call that have got 1 doctor, some 3 doctors, some 10 doctors, and you'll see in this screen there are different options on how we handle things. Now, what this basically is, before you freak out on this screen here, effectively when we're coming into here, we're getting a result coming into our screen. All right, and the doctor needs to make a decision on what are you going to mark this result as. In other words, do you mark this as a return urgently? Do you mark this as a no action? Or do you mark this as discuss, which is what this screen is talking about. All right, so when the result comes in here at the top, and these are suggestions, all right, but I certainly recommend that at your practice that you sit down with the appropriate clinicians and the appropriate practice principal and make sure you've got this codified. Because what you don't want to have happen is if you've got a 3-doctor practice, is that Dr. A does it one way, Dr. B does it another way, and Dr. C does it entirely differently, which unfortunately happens quite a bit. And certainly I think it's worthwhile, you know, for not only for accreditation purposes, but for making sure that we pick up, you know, the appropriate information for patients. God knows we don't want to have, you know, patients fall through the gaps. And if we've got different clinicians following different pathology protocols, that's when things fall through the gaps. All right. So I think it's really worthwhile. This is just a sample, as an example. Katrina actually has a blank one there for you if you're interested, where you can actually go into and actually, you know, complete it yourself and put in the blank details for yourself and put in the details that you want to have happen at your practice. All right. And so the whole idea of this is that we have a protocol at the practice that goes, right, when we get something marked as return urgently, this is what happens. Right? You've got it. You really should have that codified, because what is happening here when we come into this area here is that when we're getting a result come in, we need to have a protocol that says, right, I want the nurse to do a recall here. Right? At that stage, what I should be doing is, generally speaking, go add recall. All right, we're going to pick up our recall list. Now, be aware, All right, there's something that we introduced about 316, so it's been around a long time, where it actually picks up the subject here. In this example, general helix demonstration workflow copy, it actually brings that in as the recall reason. All right, that's how your recall list ends up polluted. All right, you might wonder to yourself, yeah, I've gone through last year and I tidied up the recall list. I got it down from 2,000 recall reasons down to 50, and within a month and a half, the doctors had added another 200. Why? How? What went wrong? This is what went wrong. Right? And the whole idea of this is that this then ties in to that other screen there. We're talking about that managed permissions originally, about managing the permissions of doctors to be able to add those recall reasons. All right, so that if I take off their ability to add recall reasons, that when I then go to add a recall, it won't bring that in. And if I do, it's going to not allow me to save it because I've got to pick from the pick list. Yay, hallelujah, says every nurse in the room. All right, because the whole idea of this is that what's happening there is that subject is creating a new recall reason. If I turn off their ability to add that recall reason, they won't be able to add that to the list. So when I go through and tie that up again Christmas this year and come and bring that down from 600 back down to 50 again, it should only go up to maybe 55 pretty quickly. Right, because we can restrict the ability for people to add to this list. Right? So once we add a recall onto that list, then, of course, we add our notation. The reason I don't want to do my notation and then add the recall is because if I do the notation, I mark it as discuss or return urgently. You may say, Grant, why don't I mark it as no action? Because why would you be masking it something as no action and mark it as a recall? That'd be a bit weird. You may ask to discuss as a recall. But as I say, generally, if you do the add recall first and then do the notation, is better because if I do the notation, it automatically moves the line down to the next line to action on my list. All right. So if I then mark this one potentially as a discuss, all right, now it's not going to happen to me now because I've only got one result in here, but if I then go discuss, it's going to move that focus line down to the next line. If I then go add recall, I'm potentially recalling the wrong patient for the wrong reason. So add recall first, notation second. All right. Once we've got that on our recall list, all right, we'll jump out of here. Let's go into our recall list, search and recall. All right, now in terms of this list here, you're going to have all reasons, generally speaking. You're going to have all users, and you're going to have here a date range. All right, please do not, I repeat, do not use date range. And if you do date range, just be conscious that it's not picking up stuff from the outside your date range. All right, in other words, if I just choose this date range and I don't have any recalls that are due on the 7th of August, I'm going to get no recalls on my list. Right? Whereas if I use due within, one of the due within ranges, say due within 2 months, for example, just as an example, it's going to pick up a dynamic date range for me. All right? It's going to pick up starting from
Seems like we just lost Grant for a minute.
No, you're right. Obviously, we've got a bit of a disconnect there. Before Grant comes back, I will just show you potentially, depending on your practice, you may also find that you may be using some sort of online appointment system or a partner company. So AutoMed systems, we've got reminders and recalls. So I have added in extra information in regards to the difference and what happens within each of them. So if there is obviously a process that you guys are manually doing the recalls through our system, you may find an automated system might be easier as well. So if you find that, you know, going through those steps a bit tedious and you don't have time because you are the practice manager, including the nurse, you may find that, you know, doing these automated sessions might be beneficial. So we've got, I've just added some information in regards to AutoMed systems and how their workflow goes. So I've also added the Katrina Cannon, Otto, sorry, wrong Katrina, sorry, Otto, sorry, I've got a colleague with that name. So basically I've added in their workflow, so you can sort of see a different workflow again to what Katrina has, as well as I've added in Health Engine and also Hot Docs. So Health Engine and Hot Docs reminders and recalls are going through the same process, where AutoMed has theirs separate. So that's why they've got 2 slides versus the Hot Doc and AutoMed. It does look like Grant's back, so I will pass it back to him.
Thanks, Kylie.
My apologies there, folks. Obviously, I had a bit of a technical malfunction there, which does happen from time to time, goodness knows. Okay, so let's start sharing the screen again. My apologies again, guys.
That's all right. While we have a bit of a lull there, Grant, we just had a couple of questions in the chat. If you delete a recall type, does it delete the recalls that are currently in the system?
No.
No. And the other question that we had in the chat is, can we restrict the doctors with the diagnosis settings too? So they need to
Good
choose
tip,
from
I
the
like
list.
it. I like it.
I would
like
love to see that happen. But
Yeah, that's a good one. And goodness knows those changes we've made around that managed permission was stage 1. All right. We're conscious that, you know, the particular user levels and the control levels we have in Medical Director are not sufficient to modern day practice, which is why we're starting to expand those permissions to enable us to make changes for that. Of course, we'd better to do that in a gradual way, because if we just change everything one day, it just, things happen. It's not a good way, generally speaking. So in that respect, we're trying to make gradual changes to that. We'll be putting more permissions in that managed permissions area moving forward. So I think I like the suggestion about the diagnosis settings, about not allowing free text. I think every PHN in the country would be cheering on that one. And I dare say many nurses too, to be fair to the crowd. So yeah, in that respect, it's probably a good tip, that one. All right. Other questions? Anything issues with the recall? That was it. We're caught up. We're good. Cool. All right. So going into the recall areas to say, please do the due within range rather than doing the date range, as I say, it just restricts how that's occurring in here. And then from that stage, you'll then sit search. Let me just go to due 2 weeks. Actually, give me a date range, because I'll then go back to 2020 something. Let's go search. All right. Now, on this list, you generally speaking will have some series of recalls. I don't have any recalls on my list, because that's the way that the goodness things of these goes. Whole idea on this list here, generally speaking, you want to be running this in a full screen mode. All right. You can run your recalls list and your patient list at the same time. All right. You don't have to just have that one window open to go back and forwards. You can do that. That reminds me also just to mention, when we're into the letter writer, how you go back to the patient's file from doing care plan stuff. So remind me to talk about that. So in regards to that, when you're in this particular list here, you can do range select. So generally what I would have this list sorted by, usually going to go sort by due date. All right. Usually it's going to get your old stuff to the top of the list. Things like, 2019, goodness knows, I've seen some there for recalls from the year 2000. For 12-month immunisation, and it's now 2024, and I think we're probably going to ring up that patient that's now 25 years of age and ask them to come back in for their immunisation. I don't think so. So probably what you want to do is sort that list by your due date. I would generally think anything prior to 7 years, you'd obviously want to get sign-off from your clinicians before you do anything there, but you can do what they call a bulk update of reasons. All right, so down the bottom here, we have our add, edit, delete buttons. If I have multiple highlights in here in terms of in your recall list, if I have multiple items in there, for example, if I had stuff prior to 7 years ago, I can do a range select all those particular options there, hit an add button on that. That will then add a particular comment to it and say, right, under discussion with Dr. Grant Smith, all recalls prior to 7 years have been marked as deleted. Then you go back through, add that comment, hit that same highlight on there, right click on the screen and delete. You have a delete button there. All right. Now, obviously, you would do that under consultation with your clinicians. Don't do any of this stuff in terms of deleting recalls until you have sign off from your appropriate clinicians as such. In terms of anyone prior to 7 years, of course, keep in mind that you may well have the children in that list. We're not actually deleting their records or marking their records as inactive or anything silly like that. But it's just be conscious of that. There may well be things prior to 7 years ago that may well be clinically relevant still, things like colonoscopies, potentially older pap smears that should now be CSTs. All that potentially could be in the list. So just don't blanket delete everything. Exercise some clinical judgment there as well, please. In terms of when they're in that particular list, managing that, quite often practices nowadays have the likes of Hot Docs and Health Engine and AutoMed plugged into here as well. They quite often will have a supplementary dashboard, which they operate outside of MD. And quite often they'll have things flagged. So if something is marked as discuss, then HotDoc will then do X. And what I mean by X is that it will then send a text now. It will send a text, 2 days from now. It'll send a text a week from now. All that's configured in those third-party systems. All right. I do recommend them. They're quite good. I certainly find for practices that are very busy and do use the recall list a lot that those Health Engine HotDocs, AutoMed type plugins are good. They work pretty good. So in that respect, certainly recommend that. In terms of the other things to do in recalls, they're the main ones, I think. In terms of actually managing the recalls in the patient's file, we're creating the patient's recall, generally speaking, within the holding file. Otherwise, we can, of course, do a recall inside a patient's file simply by hitting the recalls button up the top there. That'll then enable me to go into the recalls area. I can add a recall at that stage, pick from my list, choose the appropriate date increment range there, whether it's returned urgently or clinically significant. The whole idea of this is that when we have things flagged as return urgently, that's how we differentiate in Medical Director between whether something is a recall or a reminder. All right. We know that recalls are clinically significant. Reminders are not necessarily clinically significant. There will be an opportunity to provide preventative care to a patient. Generally, it might be some form of counselling, education, physical exercise, etc., etc., etc. They're quite often your reminders as opposed to recalls. Some practices use our recall system as a recall/reminder system, and they use that return urgently button to do that. And the way that we do that basically then is that your recalls are flagged as return urgently/clinically significant, and your non-clinically urgent recalls, which we would call reminders, are not flagged as clinically significant. And that way they can be handled differently in that respect.
Just mention something before we jump out of recalls. I'll just quickly share my screen once again. We do have the MD Insights as well. So if you are looking at getting some sort of reporting and things like that outside of the system, you do have access to that. And I've added that into the slide, so you'll be able to, generate a list and things like that outside. So if you're finding that inside the clinical software you're finding it a bit hard or you're not too sure, I have also added like the differences of what the recall action is versus an outstanding action as well, just to give you a better understanding, because I know that that can be different terminology and different, wherever you've worked before or how that works within your practice. In tomorrow's session, I do have like a workflow in regards to improvements. Sorry, I'm just looking for the practice manager one. So basically like a list of areas that you can sort of go and talk to your team about, and like this was just a quick checklist that I put together in regards to where you can sort of look for, go back in 6 months' time and see if we can improve those. So that will be a part of tomorrow's session. I think someone's already jumped on and asked for those, so definitely join and then they will automatically be sent through to you. I'll give that back to you, Grant.
Yes, ma'am. Cool. All right. So in terms of adding, as I say, recalls directly from the patient's file, we can use the add button here at the top there. Basically, it'll use, I can add my own recall reasons because I haven't turned off my ability to add recall reasons because I'm the power user around here. So I think. So I'm going to choose from the list, say, a full medical checkup and hit save. That will now have nothing on my screen. Why, I hear you say? Because I have my date range up the top left here showing as due within 1 month only. Be conscious of that, of how you have that showing. Generally speaking, for nurses, I will generally have that due 3 months. Generally, doctors, I'm going to have that 2 or 1, depending. And the whole idea here is that if I'm looking at something and I go, hang on, I want to see where that recall just went, I then select all, and that recall isn't due until this time next year. All right? So just be aware of that. That particular field there is also a sticky setting. And what that means is if I mark this as due 3 months now, I exit this screen, I go to another patient's screen, it's also going to show me due 3 months in that screen. Right? So be aware of that. Where I have had problems in the past with that, was once again that horrible thing, choose end date. where the doctor had actually put in here an end date, and it happened to be about 2 weeks before the date that the doctor was calling me going, I know there's recalls here, Grant, medical director's broken, it's horrible, why don't you have it working correctly? And it turned out it was that they'd chosen an end date there rather than actually putting a dynamic date in here, which would then be showing the appropriate result in here. Because, of course, inevitably, the doctor's then looking at it 2 weeks after that end date had elapsed. Of course, it's not in there because it's not in the criteria. Okay, so just be conscious of that and that side of things. I think we'll just touch on past history as well. In terms of making things active, inactive in here, of course, at any stage, you can always go in and edit an item. You can, once again, edit that item and recode it, make sure it's a pick list rather than the free text. Yes, I love the idea of being able to turn off the free text button, mark that one for future Kylie, put that one on the list for 4.4 if you can. That'd be a good one, I like that. In terms of summary, an occasional query I get is how do we record confidential notes in Medical Director? Using this confidential flag here, just be conscious of that. When you do the confidential flag, the doctor level users are the ones that can see this. You as a nurse level user may potentially not be able to see confidential items. All right. I've always counseled when I'm talking to the doctors, I didn't do it yesterday, my apologies because I'm running short of time, that when you do confidential items in the past medical history, that you just put an item in the progress notes that says confidential past medical history item recorded, full stop, that's it. All right. And that way, if somebody needs to come along later and go, well, you didn't actually do anything on that day, doctor. No, actually, there's this thumping great big long essay in the past medical history comment, because that's where we put our confidential stuff that needs to be hidden or restricted. Right? So if we use that confidential item there, once again, that is restricted to doctor level access. Summary basically means it will be printing in like your patient summaries. If you don't have that summary on, if you leave that off, and you want to include that in like a referral or something like that, then make sure that you have that summary flagged on. All right, because it might be something like, okay, I want the patient to, they might have been using amphetamines, for example. All right, now there would be a good time to have that on their record, but now you see we're coming up with the appropriate warnings about interaction checking and all that sort of stuff. It's appropriate. Do you wish to remove? Say no, just for the purpose of exercise today. And you'll see that now we've got their drug abuse amphetamines. All right. Now it's going to come up as active. It's not going to be showing on letters. So if I'm going to do a specialist referral, it's not going to show on a specialist referral. Now, of course, you may want to show on a specialist referral if, for example, I'm sending the patient off to a drug clinic to maybe have a look at how they're using that particular drug. So in that respect, I might want to then go, I'm going to edit that. I'm now going to turn that summary on. Go okay, send that through to the appropriate specialist clinic to look at their drug habits and maybe counsel them and do all sorts of stuff that they need to do. And then once I've done that, I'll hopefully come back into here and turn that summary off, because when I'm sending something through to their employer, it may not be appropriate to have that drug abuse amphetamines on the letter that I've just sent to them. So that's an example where you would use that summary on, summary off. Okay. In terms of keeping that relevant to the sale, I think for me, I find that the most useful way of keeping that past history items relevant is the way you open the software. Right? If you open the software and it comes straight to the summary screen, you'll see straight away family history, social history, and your past history items. Just as I say, just pick two. Don't try and if you've got the time to go through and tidy up the whole list, great, mate, well done, bonus tick. I think about 3 times ago I was at my doctor. My doctor went through and did my whole past medical history. I said, Doc, are you doing my whole past medical history? He went, yep. Hey, good on you, Doc. Well done. Good job. But I don't expect necessarily you guys to be doing that all the time. It's not appropriate to do so potentially. You may not have visibility on certain items, whether they're appropriate or not. Exercise clinical judgment here, guys. Try and adjust a couple of things. If there's a cough from 2012 I'm seeing there, is the cough from 2012 relevant today? Probably not. If the cough had hit me a few times during 2012, then it might have led to, say, emphysema or COPD, then that would be relevant. Nowadays, it's probably not relevant from a cough from 12 years ago. Exercise clinical judgment. Okay. Let's jump into everyone's favourite, creating letters. All right. unless of course got any questions about past medical history or anything we've done so far, please pop. How do we keep the sidebar hidden? Oh, you're right. Oh, okay. All right, I'll tell you how to turn it off. My marketplace people will probably hit me and go, Grant, you're not supposed to show them how to turn it off. All right, I'll tell you how to turn it off. The reason a lot of practices had it turned off traditionally, if a practice had problems with their internet, it caused all sorts of problems with the sidebar. We've actually improved it in 4.1, I think it was, for the sidebar stability, that if you lose internet connectivity, it doesn't break MD like it used to do. I'll show you how to do it. Get out of here. Got to go to the patient's file, go into tools, options, and clinical. Show sidebar. But I didn't show that, okay? Delete this from the recording. No, you don't have to delete it. But yeah, don't let Marketplace see that I've just shown you how to turn off the sidebar. They'll get very cranky at me. There are some good stuff in the sidebar these days. Fact sheets, I think, is fantastic. A big fan of the fact sheets utility there. I would keep sidebar on just for that widget alone. One of your colleagues, Chris and Judith, mentioned there about the National Cancer Screening Register one, which I don't think I have turned on here. My understanding is actually the National Cancer Screening Register was done by us at Telstra Health, and I believe we're actually expanding it into breast screening in the coming period as well. When, don't hold me to that. I'm not going to make any promises about that, but certainly I understand that is being expanded from bowel and cervical to include breast. But as I say, it's going out to tender. Where that's up to, don't ask me. I can't give you any dates because Murphy's Law or Sod's Law will jump in. And of course, if I say any date, it will not be happening by that date. Okay, so that's your show sidebar. All right, let's jump in, make a letter for someone. Let's open patient record. Yes, it's fine. All right, let's go in the old way into the letter writer. All right, let's go to the tools and we'll go to letter writer at the top here. All right, of course there is an icon there for it. It is F8 as the shortcut for letter writer. Right? And as I said, we do have the fast launch buttons down the bottom there. Let's do it the old and slow way. Let's go to letter writer. Now, if your screen is, when you come into letter writer, if it's coming up looking like this, you need to do a couple of steps. All right. What you need to do is you need to go into letter writer, go to File, Preferences, and Defaults, and just hit the Display File New button off and turn it back on again, and hit OK. Exit to letter writer, come back in again, and that screen will show on the screen. All right. 99% of users will not start writing from a blank letter. Most people will pick up a template. All right, so either pick it up from the previous screen in terms of the fast launches down the bottom, and to be fair, I would say in general practice, your number one template is going to be medical certificate. Your number two letter is going to be specialist referral. Your number three's always up for debate. That's usually something like Centrelink medical certificate or something like that. Usually first and second are a long way out, and third's up for argument. Medical certificate, specialist referral, your top two. What's third depends on your care plans. I mean, for you guys as nurses, put the 721 asthma, 721 diabetes, 721, and you do all your different templates and put them down on the fast launch. You beauty. Nice and easy, man. Budding. Let's go. All right. In terms of getting templates or modifying templates in the system, a couple of years ago, we brought in a new feature. You can blame me for this one. Where I turned off all the states in the letter writer. There is still a few of them coming in. We'll probably need to have a look at that. If you do want to, and I'm looking at the New South Wales side of things, so I'm based in New South Wales, as long as you don't hold that against me. If I do want to include all states, I click the include states, and that will then show me all the stuff from WA, Queensland, that sort of things. I am unable to select properties. Did you go through how to configure MD to open all records in summary screens? I did, but I'll quickly show it to you again just so you know. In terms of tools and options, in terms of how you open that summary screen, I'll just quickly go in there again. Go cancel. All right, no patient on the screen. Tools, options, clinical, all right, and open patient in summary. All right. Meg, would you be able to just, I'm not sure what you're referring to when you say you're unable to select properties. Properties where? If you can tell me where, I can maybe know what you're talking about. I'm just a little bit lost at that one. Sorry, mate. Let's go back out of there. Let's go back into the patient file. Yes, I know it was their birthday on Sunday. All right. So letter writer. All right. In terms of in the templates, so the easiest way to make changes or get letters changed.
Meg just answered in the blank template for the properties.
Ah, cool. All right. On the blank template. Preferences. Ah, yes, right. Gotcha. It's probably got to do with that manage preferences, manage permissions. Remind me to turn off that prompt for Medicare item number. I'm going to do that now. Give me a sec. Turn that off and turn off. No, not that one. Clinical. Mandate entering and what am I looking at? I'm looking at progress notes and prompt for Medicare item number. That one. Now, in terms of you may not have access to those properties, user and setup users, and highlight the user in question. It may be one of these in here, all right, potentially in here. It's probably one of these in here. I don't know which one, but have a check in there, please, Meg. That should enable you to get that. That may well have been restricted there. If it's not, let me know and potentially take it offline. Let me jump into letter run. Right, I'll get there eventually. All right. So in terms of these particular items in here, let's just open one up and do whatever we need to do. All right. So in terms of when you're in the letter, probably the most useful tip I can give nurses in the room, quite often you'll be in a big care plan, 5 pages, 10 pages long, whatever. And you need to go back to the patient's file to check something. It might be, I'm not sorry, I found the permissions. Could you please show me what we learned in that section in the letter? Yeah. Okay. So take that one offline, Meg. I'll do that in a sec. All right. So in terms of when we're in the letter writer, if you need to go back to the patient's file to check something, you don't necessarily have to close the letter. All right. Quite often people will hit the button there, go, yes, I do want to save changes. Yes, I do want to hit save. Yes, I do want to go back and check the progress notes. I want to check when's the last time they saw the registered nurse. It was 2002. Okay, great. Now I need to go back into that letter. Which letter was it again? It was that one. We're going to open that letter again. All this clicking takes time. That was about 15 seconds. You might go, Grant, it was 15 seconds. What's 15 seconds between me and your mates? I don't care. Fair enough. You may not. Easy way to go back from this letter back to the patient's file is use the window drop down here. All right. Go back to the patient's file there, straight in, check whatever it is you need to check. Okay, progress, whatever it is I need to be. Go back up the top here, go window again. Oops, forgive me while I just move that little screen cherry thing. All right. Click on the window again. All right, go back to the letter writer and keep going that way. There's a keyboard shortcut for it, Control Tab. All right, Control Tab just takes me between patient file and letter writer. All right. If I have multiple patients open, then I can certainly see it in here. And the easy way you open multiple patients, patient, and go to open another. I don't recommend opening up lots of patients. Usually when you get to 5 patients, medical director should warn you and say, please don't open more than 5. Reason being is that when you have open patients file, if I open up 2 or 3 patients, I'm actually loading up my computer's RAM memory. Nowadays, most practices, their workstations you'll be working on, they don't have much RAM. All right, RAM's reasonably expensive. The RAM lives on the server most of the time. So if you're actually opening up lots of patients, you're actually loading up your computer's RAM memory. And when the RAM memory is actually quite unstable. All right, so if you're running multiple patients open, you're increasing your chances of a computer error exponentially every time you open another patient. All right. So don't open multiple patients if you can. Now, of course, if you have mum and 2 kids in the room, you've got to open up all their files at one time. Fair enough. I'm not arguing. Try and keep it to a minimum of opening multiple patients because also you're increasing the ability to put the wrong data in the wrong patient's file. And yes, I know you can go back and fix it, but that's one thing you have to go back and fix. And if you didn't go back and fix it because you are human, then you've got the wrong data on the wrong patient's file, and then all hell breaks loose. All right, so let's not do that. Let's open another patient there, as I say, just for demonstration purposes. You'll see up the top of my screen, I'm now getting the open patients there up top right. I can, of course, move that around however I want to move things around. All right, and you'll also see now that I've got the window open that I can see I've got a letter there for Anna. I've got Maureen Andrews' file here. I've got Anna's file there, and I can quickly navigate back between those. All right. Can we download forms from HPOS to MD? Yes and no. What you can download in terms of into Medical Director Letter Writer is generally what they call an RTF format, rich text format. You can't download PDFs into MD Clinical. I will say you can do PDFs into MD Helix, but let's not broaden it up to them today. But certainly in terms of in MD Clinical, mainly it's RTF. So basically you want to get a Word copy, copy it into Word, control copy it all from Word into MD, and then recode the fields. Way you're generally going to do that is by file. Usually going to go for new and choose blank template. All right, so blank template. Usually we're going to go to either import at that stage to import a template into the system, or potentially what you may have got is a template from outside that you've got from HPOS or whatever. Copy that into Word, highlight it from Word, bring it into MD, and then recode the fields is probably the best way you're going to do that. What I mean by recode the fields is putting in wherever it's asking for the doctor's name, put in the doctor's appropriate details in here, into the appropriate section of the form, and update accordingly. Really useful little tip when it comes to letterheads and stuff in here. I'm just going to change from here into just a normal letter as opposed to a template letter. Is using a function called auto text, right? Edit and auto text in here. Normally I use this with our doctors, and once again, unfortunately I ran short on time yesterday for the doctors, but usually use this particular function to add signatures to doctors' letters. You go, hey, you got my attention now, Grant. So usually what happens there is I use the auto text function. As you see, I've got a couple in here already, and we'll talk about these. Is I've got one there called .lh. All right. You should find in your letter writer, if you go modify template, you should see one there called letterhead. And if you're really sharp-eyed, it's going to be very hard to see this in the webinar, but trust me, if you go back and check on your MD back in practice on your laptop, you'll see running down the side there, there's a blue ALL, just below where my mouse is now, running down the side. Right? And above it, there's another letterhead, which is pink. If you've really good eyesight there, you can see user written on the side. Right? The one you're looking for the practice is the all letterhead. All right? If you have a look at your all letterhead, all right, it's basically going to give me my practice location name. All right. Now, what I could do here is I could bring in an image or something like that. All right. Or I could do in whatever it is that I'm looking for. All right. So if I go, for example, here, I'm going to go auto text. I'm going to go, right, there's my letterhead. What's my letterhead? I'm going to go file, modify template. I want to modify that particular letterhead. All right. Currently, my letterhead is bringing in bold, 18 points, my name of the practice. Right. If I want to bring in an image, let's say I want to bring in an image of, we want to bring in that as our letterhead, so that doctors check holding file thing. The way we do this is we use snipping tool. Down the bottom here, I've got my snipping tool. I'm going to find it for you just in case you don't have yours pinned. Go into the bottom left to your start button, type in snip. Should find the snipping tool. All right, click on the snipping tool. Here's my letterhead that I want to bring into the software, for example. All right. I'm going to go, right, snip. There's my snipping tool. That's my snipping tool there. I want to bring in a rectangular snip. All right, I want to bring in this information here. That will be my new letterhead in a second. All right, so I'm going to go Control-C on my keyboard. All right, come back into MD. I'm going to go File, Modify Template, Letterhead, Open. All right, there's my particular information that I want on there. I'm going to go above that. I'm going to paste in that letterhead. Might make it a little bit smaller because otherwise it's going to probably print across the page or do something weird. All right, so we might make this a little bit smaller. All right, might need to move this one down a little bit. All right, and then we can save that as a letterhead and save. All right, so that's now my letterhead. You might go, hang on, Graham, what's it looking like that for? Because now if I go and do a blank letter, you go blank letter, right, I want to do a letterhead. Now I could go turn on my toolbar over here to the side. Let's move that out of there. Go over here and go to data toolbar. Where are you? Over here. My data toolbar there on the right hand side. I can now open that up and go, give me my practice letterhead. All right, and that's bringing that in. Now it should be bringing the image. I've obviously done something wrong with the image, but that'll be bringing that letter in there. All right. Now the whole idea of that is that when I then go into, say, for example, I jump out of here, go to our immunization summary, or do our medication summary or something like that. All right, let's go medications. All right, normally what I'll do here is you'll include the medications, you'll print this out, the doctor pulls out their stamp, they go chunk, puts up the top right there, the practice location. What you can do here is go .lh, all right, and that'll bring in the letterhead that you've just done. All right, by using that edit auto text here, by doing the .lh, that then brings in that letterhead accordingly. Okay. Now we do the similar sort of thing for doctor's signatures. If we do a doctor's signature, I'm just going to do a signature here. I'm just going to grab, say, a Mickey Mouse signature. Mickey Mouse signature. I'm going to use that same snipping tool again. All right. I want to go new. I'm going to grab some of that signature there. That's the signature the doctor wants. Control C. Now, normally what I'd get the doctor to do at that stage is to sign a nice white piece of paper, black pen, no rock star signatures. Not what I mean by rock star signatures when they do this big, you know, I want to sign, you know, the side of the car. Mate, we just sign the letter. How big is your letter when you sign a letter, right? Give me that letter. Give me that signature, not the rock star one. Want that. I don't want it says, send this one here, got like a grey background to it, sort of like a faded white back. You don't want that because it's going to print on every letter. So that's why I want a nice white piece of paper. All right, once again, Control C when it's in that snipping tool. Come back into Medical Director. All right, File, Edit, Auto Text. All right, I'm going to add a new signature. I'm going to go Add. I'm going to go .sign here on the signature. Click into here, go Control V and paste my signature. Right, now if I want to modify it, I'm just going to come into here and modify it, make it a little bit smaller. All right, might make it a bit tighter, maybe it's left, up, right, whatever it is. All right, do not make this available to all doctors. I'll repeat it again. Do not make a doctor's signature available to all doctors. Bad. Because you want each doctor having their own signature, right? No point in having everyone's same signature. That's pointless. All right. Then go OK. I close. I've done my letter here. I want to put my signature at the bottom of this letter. .sign. Enter. There's my signature. When you do this, you may well find that you need to go into your templates and modify the amount of space you've got between your signature and the bottom of the letter, because quite often your signature might be a little bit bigger or whatever. You can modify that as well. But that's the secret to doing signatures, to doing letterheads in Letter Writer. All right, and the secret there to going back to the letter in terms of the patient's file, window, go back to the letter, or back to the file, then I go back to the letter, go back to the letter, keep going. So especially if you're in big, long care plans and you go check multiple things, that Control tab or that window button there, awesome. Okay. Conscious of time, I think we've covered just about everything. My Health Record, should we touch on that?
Might be good, Grant, to ask if there's any further questions so everyone can get back to their...
Yes, that's true. Just before we do, I just realised that I haven't touched anything on My Health Record, accessing information, uploading, and that's I can do a blitz on that one. My Health Record at the top here is how you access what's on the My Health Record. In terms of your accessing a patient's My Health Record, click into there. And of course it won't let me because I don't have the appropriate details, but normally what will happen there will come up with the appropriate window for my health record. On that side, having the signature in letter writer, no, I'll potentially do one for you, Alice. In regards to uploading stuff into my health record, the most common thing we're uploading into my health record is generally going to be shared health summaries, because that's what we upload for our EPIP and PIPQI incentives. Generally, the way we're doing that is from our letter writer again, letter writer, and we've got over here, we've got our eHealth button here, and that's where we're going to do a shared health summary and hit OK. It'll take me through a appropriate guideline here in a minute, or maybe not, as the case may be, where I then open up the shared health summary and complete the shared health summary, upload from there. All right, as I say, conscious of time, as per Barb's recommendation, any questions, please, folks? Alice, I'll try and get you a guide on how we do signatures in letter writer.
Will be one in the actual template that's sent out to them, so it'll already be in there.
Well done, Coles. All right, Barb, Tara, probably back to you, Tara. Can we make the care plan a shortcut template? Yes, you can. Yes, you can make that a shortcut, absolutely. Once again, the way we do that, click on our three little buttons down the bottom there. Let's go in. I want to do a letter template. I click my button over here on the right-hand side. I choose, just for example, one of our supplied ones. Let's go care plan. If you could spell care, of course. Let's go care plan. Actually, I know where there is one. Let's go GPMP, because I wrote this one many years ago. All right, I'm going to call that GPMP. All right, save. Then you now have the bottom there. And now you have to exit before you freak out. I fixed it. Good, you have to exit. There is now the GPMP, and you just launch straight into the GPMP. You used to have to close the patient's file and come back in before the change in effect. Now the change is good. So yes, you can do that. Great. Otherwise, I think we're good. Tara, over to you. I think we're closing up.
Yeah, thanks. So just being conscious of the time. Thank you, everyone, for attending. Thank you, Grant, for that wealth of information that you've just given us, and Kylie as well for your input and for those great slides that have so much more information than what we can do in 2 hours. Just want to let everyone know that we do have one more training session for the medical director, for the practice managers, which is tomorrow. That should be showing on your screens. Hopefully my screen sharing is okay, that you can see that in front of you. Perfect. Thanks for thumbs up. And just got the details there so you can see that on your screen. Also, just if you can all just whip out your phones, and if you can just scan the QR code that's on the front of you and on the screen, that's just a general feedback of good, bad, ugly, and just some topics that you'd like us to cover in the future. If you'd be interested in attending a training like this again, what topics you'd like to go further in detail with, and then I'm sure we can organise another training session for you all. Again, we'll wrap up. Thank you everyone for attending. Have a wonderful rest of your Wednesday, and thanks again, Grant and Kylie. Thanks all. Have a good rest of the day.